So another study we did was a 5-year randomized controlled trial, which is the gold standard of clinical treatment research. By gold standard, I mean when you do a randomized controlled trial, the beauty of that caliber of study is the results that that trial demonstrates are known to be able to be applicable to any students like that was in the study anywhere in the world. As long as they're of that same makeup, that same constitution, that same IQ cutoff, or levels of disparity between skills and abilities cutoff. Like, let's say we were looking for students who had IQs in the low average or above range, so like 30th percentile and up, and we're looking for students who had reading skills below the 5th percentile. Then what findings we get in this randomized controlled trial would apply to any student anywhere who had IQ 30th percentile or above and had reading skills below the 5th percentile. That's why you do randomized controlled trials. It takes away having to guess and wonder if the outcomes from this study would have the same outcomes in Mrs. Jones' classroom, or kids in Montana, or kids in Mississippi, or kids in California, or kids in Florida, or kids in Alabama. We don't have to wonder if that's going to be the case because the brain works the same for any child anywhere in the world. The difference is, what are we doing and how are we identifying those children that need the help? So when you do a randomized controlled trial, we then have a better confidence that the outcomes we've found will be applicable to students anywhere in the United States and in any English-speaking country in the world. So we screened and brought on board 60 children who had reading skills below the 5th percentile. They had average or above IQ, they had phonological processing skills that were deficient, and they were already in special ed classrooms, and they already had a diagnosis of dyslexia, or what's also called a specific learning disorder with impairment in reading. So we took the students, and 30 of them got our neurodevelopmental approach of treatment, which starts building the language processor at the speech level of neurology, not at the letter level, not at the phonics level. It's what happens below before you even get to the phonics. So those students got 2 hours of one-on-one sessions per day, 5 days a week, for 8 weeks. This was not a study of the program's full effectiveness because they were not allowed to finish the program. All they were allowed to do was get a small dose of treatment. Why? It was financial. That's all the grant could afford to do. Even if you have $1 million project, there's only so much you can do with that money that at some point you've exceeded your budget. So they got their 2 hours a day, 5 days a week for 8 weeks. And in that time frame, we saw their ability to sound out words go from the 5th percentile all the way up to the 45th percentile. That's grade levels of change in just 8 weeks. Sadly, many parents have been misinformed by less effective programs and by those who believe in less effective programs that that's impossible. You can't make that kind of change in 8 weeks. And they're partly right. You can't if you use programs that are not evidence-based. You won't make that kind of gain in 8 weeks if you're using a program somebody made up. It doesn't matter if that program's been around for 70 years. If that program does not have high-caliber, evidence-based research showing that it's highly effective, and all it has is a bunch of people who say we like it, we think it works, that's not likely going to have the same results because it's not a evidence-based, scientifically proven to be highly effective program. But the real measure of a program for those 8 to 10-year-olds is what happens when the treatment stops. What happens when they go back to their special ed classrooms? Which, by the way, one report listed that in the United States, if you have an IEP and you're in special ed, only 5% of those children are going to close the gap enough to be discharged and leave special ed and no longer need those IEPs, so that individual education plan. Because typically what's happening in IEPs and special ed is we're making accommodations for the symptoms of the difficulty. We're accommodating for reading is harder. We're accommodating for spelling is harder. Or teaching them how to compensate for their difficulty and try to work around it. We're not actually seeing school systems do things that actually address the cause of the problem. So when you address symptoms, you're always going to need to keep providing those crutches or those workarounds because you have never really addressed what was causing the problem to begin with. So when those students went back to their special ed classes, we brought them back a year later to measure their skills today. Where are they now? They got a dose. Did it stick? Did it drop? Did it go higher? Did nothing change? The only way to find out is you have to measure it scientifically. Not just because you tracked one child in one classroom in school, not because one school district reported on the data for one classroom. Those are not scientific data. Those are anecdotal studies. They have all kinds of bias in them. They're not reliable, and their findings do not apply to any students anywhere in the world who are English speaking because those pieces of data were not collected from a scientific method, scientific design study. What we found was the reading and comprehension skills of those 8 to 10-year-olds who got that neurodevelopmental approach that had gone from the 5th percentile to the 45th percentile continued to improve even a year after treatment had stopped. But that wasn't enough. We brought them back 2 years after treatment, and we measured their skills again. And here they were at post-treatment, here they were at 1 year after treatment, and here they were at 2 years after treatment. Their trajectory of growth continued to increase without additional intervention. And that statistic I just shared about only 5% leave special ed, we blew that one out of the water because 40%, not 5, 40% of these children left the special ed classrooms. They no longer qualified for services because we had closed the gap between their potential and their current level of function in their ability to read with accuracy, with fluency, and with comprehension. Now, across the whole group, there wasn't a large change in their reading speed. We weren't surprised, because when you're developmentally trained, it's not a big, complex thing to understand that if I just teach you a new skill, like you just learned how to read, because remember, they were at the 5th percentile. They did not know how to sound out words, or at least they had no idea how to do it accurately and efficiently. So in 2 months, we just taught them how to sound out words. Would I expect them to be as fast as a child who'd been sounding out words for 3 to 5 years? No, of course not. So it would not be an expectation, nor was that study designed to say, did we change fluency at the same time we changed phonological awareness and decoding skills? Why? Because when we designed that study, there was no evidence that we were actually even going to be successful at going from the 5th percentile to the 45th percentile. There was no evidence that said we could actually even change these skills and accuracy. Our anticipation was 1 to 2 years after they've got the skills, then you'll be able to see the growth in the speed and efficiency of the reading activity. Because when you first learn how to ride a bike, we should not put you in the Tour de France in a few weeks, because the people you would be competing against, even though you both had the same knowledge of arguably how to ride a bike, how to use the pedals, how to use the handlebars, how to lean, steer, you did not have the same level of finesse and expertise as someone who'd been practicing it for 10 years. But when you started to put those skills into practice and build those skills into that automaticity, then you start to see the gap closing. And in those students, 1 to 2 years after treatment had ended, then their fluency skills had caught back up to their peers. So yes, it is possible to change reading fluency, but you first must build the lower level skills, which are the phonological skills, the decoding accuracy skills, and you want to be sure the comprehension skills are on board as well. When those 3 things are strong, then we have a much better chance that they're going to see continued smooth growth in the reading fluency and those grade level and above reading comprehension skills. Because what's the purpose of reading? It's to comprehend.